This is Dr. Charles Parker, and you're listening to Core Brain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street. Well, welcome aboard, folks. Dr. Charles Parker here one more time. We are very pleased. We've been doing a series over at Core Brain Journal specifically for vets, because we know vets are a very large group of individuals that aren't being addressed effectively. And I think we've got at today's recording 18 different episodes that are trauma and traumatic brain disorder and vet related. Let's put it that way in the larger picture. But today we're going to deal with trauma in a different and even different way. And today we have Dr. Susan Drury. Welcome, Susan. Glad to have you here.
Glad to be here.
Now, Susan is going to tell us, I'm going to tell you a little bit about her. I'm going to introduce her. And then she's going to tell us in our little prep here talking before we got started, she's got an interesting thought that's going to be relevant for practitioners as well as clients in terms of how they approach their recovery from issues that are traumatic. So to introduce her, Dr. Drury is a consulting psychologist for Sovereign Health of Arizona at the Chandler, Arizona Women's Facility. She received her PhD in clinical psychology from the esteemed University of Chicago. She has over 35 years of clinical experience, including EMDR, which we do intend to talk about. We've dropped that EMDR out a couple times, and we're going to get right into it today. And then traumatic incident reduction and other specialized trauma treatment techniques. She is a certified trauma specialist with the Association of Traumatic Stress Studies and a certified clinical trauma professional with the International Association of Trauma Professionals. Very deep. Suzanne is the professor in charge of the specialty program at Ottawa University, some distance from Arizona, I assume.
No, it's actually a version of Ottawa. It's Ottawa, Kansas, and it's Arizona based. And I'm actually not there anymore. When I started at Sovereign, I moved out of the teaching job, but I'd be happy to talk about it.
Oh no, that's interesting. I was as I was reading this over in preparation, I was like, I don't know how she's putting those two things together. So, but are you still teaching at Grand Canyon University and Argosy University?
No, I'm actually working full time at Sovereign,
Gotcha.
And I've got to say, this job fell into my lap, and it's the perfect job for me. I had no idea how much I would love residential treatment, because one of the things that was frustrating about working as an outpatient therapist is clients don't have enough support because they just don't have the support system around them. The women that are here are as important to each other's healing as we are as therapists.
Now, Susan, say that again. Get a little closer to your microphone, please, because you're fading a little bit, and I was trying to turn you up here, but I couldn't quite turn you up. So say what you just said again, if you will, please.
I love working with residential treatment, and I didn't realize the women here are as important to each other and to their treatment as the therapists are, because they have 24-hour support, and we need community to heal. Mm-hmm. Trauma is really frightening, because your brain and your body are so dysregulated. It's like being in fight flight all the time. Mm-hmm. And it's extraordinarily painful. And so what we find is clients will do anything they can think of to stop the pain. What we know, for example, is that substance abuse is one of the ways people self-medicate trauma symptoms. They're trying to get their bodies to calm down. And so we now can look at people with a traumatic background with incredible compassion, because no matter how dysfunctional their behavior, they're doing the best they can to figure out how to survive. And most trauma victims are frightened. And so you and I were talking a little bit before we started. I taught counselors how to treat trauma. And one of the things we worked on the most is you can't do trauma work until you do safety and stabilization. You have to help clients learn how to self-regulate, to calm themselves down, to soothe their body. And what we find is the brain changes that occur as a result of trauma, which is that the amygdala, the little fire alarm, is firing all the time. And when you're getting that fight flight, your cerebral cortex shuts off. So you're not able to think, problem solve. And so first thing we've got to do is figure out how to calm, how to stabilize, teach people breathing, teach them mindfulness, teach them meditation, teach them to regulate their bodies and their emotions so that they can begin to do the work and be safe while they're doing it.
Well, that's interesting. Let me ask a point of clarification, if you will, there, because that's very interesting. I want to hear more about that, but I want to take it one word further up the line from what you said, and that is safety. So how do you help a person? I understand the beginnings here of the conversation with stabilization. I look forward to talking more about that, but safety, how does that fit into the preparatory work? How do you cognitively help them establish a greater sense of safety so they can actually participate in the recovery process?
One thing is, with trauma, we have to do a lot of psychoeducation. We teach people what's happening in their brain. We show them brain scans. We help them understand why they're feeling the way they are. And then we also have to make sure that we create a non-judgmental, accepting environment so that most of them have had really painful interpersonal relationships. So if we come on too strong, or we're judgmental, or we don't take the time to meet them where they are, we end up just repeating the experience that they've had before. And then they get frightened and they can't do the work.
So what you're saying is one of the things that everybody structures is a sense of connectedness. And through that connectedness is the safety in the very beginning, even in terms of their own interpersonal relationships with each other. So
you bet.
There's a sense of security that this is how we're going to handle people in this environment, so that everybody has that basic game plan. You know, there is a first, second, and third base. I mean, you have some rules to the game, and if you follow the rules, then everybody's going to be okay.
Well, and most of our theory about treating trauma is about a 3-stage model, which is safety and stabilization first, then trauma processing, and that's where EMDR is useful, and then what we call reconnection, which is creating a life after trauma, creating a vision of a life that's worth living, and then beginning to create a life for yourself that works again.
Well, that's very interesting. Let's run the tape back. I do understand the preparedness and the structure with safety, because that helps the everybody feel that the communication process is going to be supportive and safe. Now, running back on the stabilization, so do you have, as part of your program then, is meditation something that happens every day? Is it a couple times a day? How does that structure actually occur in the program?
We do meditation, we do yoga. We also are now a DBT, dialectical behavior therapy focused program. And they do a lot of skills training on distress tolerance, on emotional regulation, on interpersonal effectiveness. So every day clients get tools. For example, one of them that I didn't know about until I studied DBT is if a client's completely freaked out, giving them an ice pack can sometimes help them calm down, or teaching them to do deep breathing can help them to calm down. So we're giving them a set of distress tolerance tools before we even start doing the trauma work.
How do you use the ice pack, Suzanne?
You can have somebody put an ice pack on the back of their neck. In DBT, they even sometimes have people put their face in cold water or put a cold washcloth on their face, because what that does is calm down the dysregulation. One of a whole lot of tools that we teach.
So then what happens with, those are some techniques you use. You've established sort of a cognitive grid. Here's how we're going to relate to each other. Here are the tools that we use for stabilization, so everybody's comfortable with that. Now, EMDR, I've always seen it. We do EMDR in our practice here, but I've seen it as a individualized process. Is it not individualized there, or is it individualized, and how does all that work in your facility?
That it is individualized. We also do something, and I'll talk about EMDR in a minute, but we do neurofeedback as well, where we help the brain re-regulate. So it looks at what parts of the brain are overactive and then helps the client to do processing so that they can bring their brain back to stability. For example, lots of people with PTSD have nightmares. And we find that after 4 or 5 sessions of NFT, often their nightmares go away. Because the brain is starting to balance itself out. So yes, EMDR is an individual process. Would you like me to say more about it for your listeners?
Yes, if you would, please. Now, NFT is neurofeedback treatment. That's your acronym for and NFB is neurofeedback. That's another acronym that people use. But NFT, so you really do an admixture of NFT and EMDR.
Yes. Actually, if people are interested, one of the very best books that you can ever read on trauma is a book by Bezel van der Kolk called The Body Keeps the Score. And it's a history of his whole career and what he learned about trauma. And he highly recommends both EMDR and NFT as being critical for trauma treatment.
Well, that's very helpful, and I'll include that in the show notes for people who are driving to work when they're listening to this. So, if you would say some more about EMDR, because I think that it's almost incomprehensible that it could be useful. It sounds so completely flaky when at least when I try to describe it. I don't think my vocabulary is developed well enough to really talk about it, but we would all appreciate it if you could tell us more about that.
What it is when we're traumatized, if we don't process the memories, they kind of get stuck. And it's like you've eaten a big meal and you haven't chewed your food and digested it. And so it's kind of sitting there like a lump. And Francine Shapiro, who developed EMDR, discovered accidentally that if you use bilateral stimulation, and she started with eye movement, which is moving right and left, moving your eyes right and left like you do in REM sleep, that what it did is it freed the brain to begin to process the trauma. And she had incredible success with veterans who had had terrible PTSD for 10, 15 years, 20 years. And she was able to help them process those memories. But it's an interesting process because it's both cognitive and emotional. What you do is ask the client to get a picture in their mind of a traumatic incident, and then ask them, what negative beliefs about yourself did you have as a result of this trauma? And a client will say something, I'm not worth anything, or I'm not safe. And then you ask them, what belief about yourself would you like to have? And they'll say something like, I just worked with a client today, I'm worthwhile. And then you ask them to look at the feelings that are stirred up. I use actually little vibrating buzzies that you hold that do right, left, right, left, right, left. And you'll just say to the client, okay, hold that image and that belief, I'm not worthwhile, and go with that. And we tell them, your brain knows where to go. You don't have to do anything. Just see where it leads you. And then you as a therapist follow wherever the client goes.
Okay, stop right there, because I'm with you in that moment, but I want our readers, our readers and our listeners to think a little more about this. First of all, what does EMDR mean? And then we want to get the word buzzy, and then we want to go back to where you were with the client at that moment. So tell us about what EMDR means.
It's eye movement desensitization and reprocessing. Big word, but it's really about bilateral stimulation. Right brain, left brain. Bringing both parts of that brain, of your brain, into that processing process.
And then when you said buzzies, go ahead. Sorry.
I don't know how to describe them. They're little paddles that buzz in one hand and then the other. And they provide bilateral tactile stimulation so that you're getting right, left.
Are they they buzz like they run with a battery, or how does that actually happen?
Yeah, they run with a battery.
Okay, I got you.
And it's really interesting when they do EMDR with kids, and they can actually do it with kids as young as 18 months. They put the buzzies in their socks.
That's interesting.
So they do play therapy or talk about the situation, and they have buzzies providing bilateral stimulation while they're doing that.
Now, is that buzzy back and forth stimulation set on the machine, or does the therapist actually control?
You can control the speed, the intensity. And even when you do EMDR, you do a lot of preparation. You do safe place. Picture yourself in a place where you feel really safe. You teach them breathing, stabilization techniques before you even start the EMDR process. I don't know if that's clear enough about the buzzies. It's hard to describe them.
No, I think that does help. And I think the other thing, if you could elaborate, because I know just a little bit about it, the whole eye movement piece, because people may have heard about that, may have seen it. Could you describe that a little bit?
There are some people who believe that the eye movement is much more powerful than the tactile stimulation. So they will have the clients think about the incident and move their eyes back and forth. Or you can buy a light bar where you follow the light right and left. And I tend to use the buzzies because personally I couldn't do the eye movement. It made me dizzy. So
if you did it all day, you'd fall on the floor.
Yeah, besides which, I'm old enough that moving my fingers back and forth in front of somebody's face for 45 minutes is tiring.
Gotcha. Yeah. Well, that's interesting. It really is interesting. So then how long does it take a person doing this, and what do you experience with the human being there in the room when you're doing this? What kind of things take place?
One is you keep your mouth shut. All you as a therapist say is you do about 25 passes, and then you say, take a breath, let it go. What do you get now? And then you'll say, okay, go with that. And you literally just follow wherever it leads. And you also measure their subjective units of distress scale before they start. So our clients are often at a 10. We're dealing with very severe childhood trauma. And when they finish, we want them to be at a 1 or a 2 on the SUD scale. In other words, we want them to be able to think about the incident and not feel that intense hyperarousal. And remarkably enough, it works incredibly well.
Mm-hmm. So how long is the program for excuse me for interrupting, Sue, but I mean, what's the length of the program that you have there at Sovereign? What is it, a week, 2 weeks?
We're a 30, 60 to 90-day program.
Okay.
We're dealing with women who are severely, severely traumatized, have failed out of 4 or 5 other rehabs for substance abuse. They've made frequent suicide attempts. So we're dealing with people who are really struggling. And with EMDR, it depends on the amount of trauma and the depth of the trauma. You can get significant relief in relation to a particular incident in one session, but to completely clean up a series of traumatic incidents, you'd have to have multiple EMDR sessions. But it's not like it used to be. When I started working with trauma, I felt like I was bailing the ocean with a teaspoon. It took forever, and the patient was suffering for years. EMDR, you can get significant relief in a relatively short period of time. And it's a remarkable process. Let me just tell you about one client. And she had only a couple of incidents of sexual abuse, but she was so traumatized that she had trouble having sex with her husband. We did an EMDR session, and at the end of it, she got to, I was only 5. It wasn't my fault. she came in the next session and said, I've been having sex with my husband and it's not bothering me.
That's amazing.
It's amazing. And it takes a while for you as a therapist to trust the process, that it really does go where it needs to go, and that clients can move through the trauma, and you can actually see the changes on brain scans. There's a woman, and I forget her name, who has brain scans of a first responder before EMDR, during EMDR, and after EMDR. And it's like the brain is totally different.
Yes, I recall that. I don't recall her name right now, but I worked with Dr. Amen for many years, for 4 years. And
Okay.
We and her name isn't occurring to me right now, but she was very involved with first responders there in California, in Newport Beach.
Yeah, and I don't remember her name either.
Yeah, but she was a delightful person, very, very well educated about EMDR, and I think at the time, this is back in 2003 or something like that, Dr. Amen was just becoming more interested in it. So it's been a while.
I think what Van der Kolk says, and a number of other people, is if you're going to do trauma work, you need to be trained in EMDR. That's because it's such an effective method for helping people process trauma, that not knowing that would be like working with a half a set of tools.
Mm-hmm. Well, let me ask you this question. I got two questions that are occurring to me, and perhaps with others. Number one is, do you use medication during this program? That's number one. And number two, do you have, I know at Sovereign, because I've talked to several individuals with Sovereign, and the thing is very characteristic and very useful and helpful about Sovereign is they do have a strong aftercare. Do you do kind of an ongoing EMDR process where people return and work things through, or is it finite at the end of the program? How does that work? So medication and continuity, those are the two questions.
Medication, yes, of course, we do use medication. We have a lot of people who have a diagnosis of major depressive disorder or bipolar 2, and we need mood stabilizers or antidepressants. So we have a psychiatrist. All of our patients see them. Most of our patients take medication. In terms of aftercare, what we do is before a patient leaves here, they have an appointment with a therapist and a psychiatrist in their own community. And usually if there's someone who's been doing EMDR, we will refer them to a therapist who does EMDR so they can follow up with the process. So they leave here with an appointment.
That's part of the reentry process, and so let's talk about even more specifically about the reentry process and what that continuity is like for your program.
One of the other things we do is we do family work while people are here, so that we can help them resolve issues with their family and engage family support for when they leave. We also strongly recommend support groups. Codependence Anonymous, Narcotics Anonymous, Emotions Anonymous, Alcoholics Anonymous, because we believe that people need ongoing support, that you can't do this alone.
Mm-hmm, mm-hmm. Yeah. Please go ahead.
We also want to get people to develop a vision of how they want their life to be, so that when they leave, they can begin to create a more nourishing life for themselves. I did an exercise the other day in group. I said, imagine a day 3 years from today when you're healed. And I want you to write a letter from that self to you now, telling what your life is like and what you've learned that got you there.
Oh, yes. Mm-hmm.
That was a really powerful exercise.
It would be. That sounds very interesting. I mean, because in that situation, it's sort of like imaging the going over the pole vault. I mean, you have to get yourself all the way over that bar in your mind and be on that other side to actually have a place to go in reality in the moment.
Well, and the other thing is, it isn't enough to stop the negativity. There's a guy named Rick Hansen who's written a book called Hardwiring Your Brain for Happiness. And there are things that you have to put in your life to create a nourishing life. So it's not enough to just get over being a drug addict. You have to get a life. And so we want to help people get a life. And we have clients say when they leave, I feel like I got myself back. Mm-hmm. Mm-hmm. We have a video from one of our clients, and I'll try to find the link to it and I'll put it on the site, because she really describes what happened for her in the treatment process, to give people a feel for what it's really like.
Gee, that would be great. We really appreciate it, because I could just load the video up on the show notes. It'd be easy to do that, and it would be of interest. Absolutely.
I'll also send you a little short article I wrote on safety and stabilization and what that requires.
Oh, that sounds great. That would be fantastic.
There's also a book that just came out in the last month, and I'll send you the reference for that. It's called Forward Facing Trauma Therapy, by Eric Gentry. And he works on create the vision first and then do the trauma treatment, but it's all directed toward allowing yourself to remove the barriers to being able to live that life that you envision.
Well,
so I'll send you.
Yeah, those sound like very interesting references, and we'd be happy to include them. So our time is kind of running short here. We've had such a delightful conversation, and there's so much to talk about, and I really appreciate the real the experience of just sharing this with you, because it's easy for us. I mean, this is what's really neat about podcasts, because you're really right there with the person. You can imagine the situation, and having these other references in the video will help us further down the road. But it's fun to talk to. I haven't really heard about the 3 levels that you're talking about. I can imagine that third level would be particularly difficult. In closing, I'd like to hear you say something about it with individuals who've not only been traumatized, but then have the whole business of substance abuse recovery as well. Are there any specific nuances with substance abuse recovery that are superimposed on or parallel with the recovery from trauma?
Yes, because our belief is that often people are trying to self-medicate their trauma with the substances. And so if we treat somebody and just focus on the addiction, they're going to go out and relapse. Mm-hmm. Because if they've still got all of the dysregulation and they haven't learned the tools and they haven't dealt with the trauma, then they go out and that stuff's going to flood them and they're going to say, hey, heroin worked. Let me try that again. So we have to help them stabilize their organism so that when they go out, they can stay sober. They've got to have other tools to deal with the pain.
Suzanne, this has been so helpful. We really appreciate it. Let's close with where you would like to send people for any specific closure ideas, whether it's a place, an idea, something to pursue as we close.
Again, I will send you the forward-facing trauma therapy reference. I think I already sent you the Vanderkolk reference. And there's another wonderful book by Francine Shapiro called Getting Past Your Past that's about EMDR for lay people. So I'll send you that reference as well.
Oh, that's great.
And know that there are resources out here. You don't have to live with it forever. There are ways to heal.
See, that's so important to end on a positive note like that, because so many people are lost. I mean, the issue of the confluence, the interrelationship between cognition, thinking about it, and the emotional dysregulation just winds up being a hornet's nest. And
yes, it does.
Because you can't think about it straight if your emotions are messed up, and on the other hand, you can't get your emotions straight if your cognition's all over the place. So.
Yep.
So, well, listen, we're going to wind up. Suzanne, thank you so much for taking the time. I'll look forward to including these books and references. They'll be there, folks, on the show note. And as I may have mentioned, I don't know if I think I mentioned it to Suzanne before we started, but this is the 100th episode, so it's going to be fun. We'll have it right up there and be easy to find over at Core Brain Journal. So we would look forward to doing this again sometime, Suzanne. Thank you very much.
I loved it. It was fun. Thank you.
Appreciate it. We'll do it again. Have a good one. Thanks for listening to Core Brain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at corebrainjournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.